Hello, everyone. This is Dhiraj Gupta from Liverpool in England, presenting to you the next edition of the Journal Club for our online journal, Arrhythmia Academy. Now, the issue that we're going to be discussing today is a very interesting, a very contentious one. How do you define atrial fibrillation? Now, we know that the classification of atrial fibrillation is largely based on temporal criteria, with paroxysmal atrial fibrillation representing the longest documented episode between 30 seconds and 7 days, short-lasting persistent AF between 7 days and 3 months, persistent as between 3 months and 12 months, and long-standing persistent AF as beyond 2 months. So we realize that this kind of classification is quite arbitrary, but for better or worse, this has stuck. Now, it does help in the management decision for patients, but there is still very little evidence underpinning this. Now, things have changed over the last few years with the advent of implantable loop recorders. We now have these tools which are capable of constant 24/7 monitoring for patients. So it gives us much better idea of what kind of AF burden we are dealing with. And also it helps us decide as to what should be the optimal cutoff for these classifications. So as such, I was struck by a recent publication in the JAMA network of journals looking at precisely this issue. This was based on the pivotal CIRCA-DOSE study, which a number of you may have come across, which was presented as well as published recently. The study design was very simple. Essentially, it was looking at patients with paroxysmal atrial fibrillation who were being randomized to state-of-the-art cryoballoon PVI or state-of-the-art contact force-based radiofrequency PVI. The real USP of the study, in the opinion of many people, was not that, but with the fact that all of these patients underwent a loop recorder a couple of months prior to their AF ablation. And that allowed the investigators to really look at the AF burden and the temporal behavior of AF in detail. So I'm really delighted today to be joined by the principal investigator of CIRCA-DOSE, Dr. Jason Andrade. And he joins us all the way from Vancouver, British Columbia, Canada. So welcome, Jason. It must be a really unearthly hour for you there, but thanks very much for joining us. What I would request you to do is present the data behind CIRCA-DOSE and behind this study, and then we can have a little chat for our viewers about the findings of the study and in what context we can place them.
All right. Thank you so much, Dhiraj. It's so wonderful to join you. As you mentioned, I'll take you a little bit through the background of CIRCA-DOSE, just to explain how the study was designed, and then that'll allow us to launch into the more recent analysis that was just published. So the CIRCA-DOSE study was a randomized study. It was conducted at 8 centers across Canada. So it was actually coast to coast from Vancouver and Victoria in the west all the way to Halifax in the east. What we did was design a study where we really wanted to drill into the contemporary tools. So we had contact force-based RF ablation as one arm. We had a standard cryo balloon ablation arm, and then a short freezing duration, which was based on some animal work that we had done previously. We wanted to have a definitive technology comparison, so we used loop recorders as the continuous monitoring answer to the question to try and evaluate which one may or may not be better than the other. We wanted to have a sense of how PVI as a ablation strategy influenced outcomes, so we put in loop recorders in everyone several months in advance. The median time from loop recorder implantation to ablation was about 74 days. So we had a good baseline in the majority of patients. Patients were then randomized the week before ablation. There was no exclusions based on anatomy, so very much reflective of what we do for clinical practice. And then patients were followed for a year. All of the loop recorder tracings were overread by a minimum of 2 cardiologists, potentially 3 in the case of disagreement. So there was good adjudication of the arrhythmia events, and we also relied on arrhythmia burden. So those things, I think, are the novel pieces of the study. When we look at the population that we included, we essentially included a fairly typical population for paroxysmal AF, so patients who are just about 60 years of age. About 2/3 were men. The criteria was non-permanent AFib with a focus on paroxysmal, but we had about 10% who were traditional definition of persistent AF. Most were symptomatic, so we used the CCS SAF score, which is very similar to the ERA score. So about 2/3 of the patients were 3 or 4 on that scale, so highly symptomatic patients. Clinically, they were describing 4 episodes a month. They had failed 2 antiarrhythmic drugs by the time they got to the study. So a reasonably well-treated population representative of what we would call paroxysmal AF. What the study showed, firstly, in terms of the procedural parameters, was cryo was associated with a significantly shorter procedure duration and a significantly shorter left atrial time. In terms of absolute numbers, the numbers are high, but we built in a secondary evaluation. So we put a 20-minute observation period, then did adenosine testing for dormant conduction in every patient, and then eliminated the dormant conduction if it was there. So it sort of inflates the total procedure duration. I'd say that those things are not necessarily standard for most cryo cases at this point, but we wanted to know if adenosine was important in this population back when we designed the study. On the flip side, the fluoroscopy times with cryo were higher than what you saw with RF. So our median fluoro time in the RF arm was 5 minutes, which is quite low. If we look back at something like fire and ice, the RF time in that study was about 17 minutes, so much higher than what we observed. For us, our cryo RF or fluoro times were very comparable to what they were seeing with RF and fire and ice. In terms of arrhythmia outcomes, now remember that this is continuous monitoring with a loop recorder. So this is recording any single arrhythmia event. The minimum recording duration on the loop recorder is 2 minutes to trigger, but all of the events were overread and adjudicated. And so if the episode was longer than 30 seconds, it was considered a significant event, and then that was adjudicated as a study endpoint. So if you take any atrial arrhythmia, so AFib, aflutter, atrial tachycardia, longer than 30 seconds, detected on that minimum loop recorder interval, or detected on a Holter, or detected on an ECG, however you found it, then that counted as a study endpoint. And so what we saw was a functional, if you want to call it, cure rate of somewhere in the range of 52%, so no more than 30 seconds of arrhythmia. Importantly, there was no difference between contact force, long duration cryo or short duration cryo. So very similar curves with very similar endpoints. The key thing to remember, though, is that when we look at studies of AF ablation, typically the endpoint that we're seeing is not any atrial arrhythmia. Typically what we're seeing is symptomatic atrial tachycardia, so fib, flutter, or atrial tachycardia that resulted in symptoms, resulted in the patient activating their transtelephonic monitor or coming to medical attention. So this is what you would have seen in the landmark contact force studies such as SMART-AF. If you look at that outcome, then it was sitting closer to about 80% freedom from symptomatic atrial arrhythmia, which is actually very good relative to the previous studies. Again, we don't see much in the way of a significant difference between the studies. What you're seeing is a very consistent outcome across the technologies. But the key thing for us, because we had the loop recorders, is we were actually able to evaluate AF burden. So AF burden was defined as the percentage of time the patient was in atrial fibrillation. And what you can see is that when you compare that pre-ablation interval, which is, as I say, about 74 days, and then you compare it to the year post-ablation, you see an absolute reduction in AF burden that was substantial. Relatively speaking, the decrease is about 99%. In the case of the cryo 4-minute arm, it was a 99.9% reduction from baseline. So from what I've taken away from this, when I talk to patients about their procedures, I say, the chance of curing you of every atrial fibrillation or atrial arrhythmia episode is in the range of about 52%. But compared to how you are now, we would expect about a 99% improvement compared to what you had previously. When we look beyond arrhythmia outcomes, so we did an extensive quality of life evaluation. This is just the effect score analysis. We also use the EQ-5D as well as a symptom score. This is a disease-specific quality of life instrument. You can notice that at baseline, so the left part of each of the 3 clusters, patients were severely impaired in terms of their overall symptomatology. So their effect scores were just around 50. In the 6 months following ablation, there was a substantial improvement, and that improvement persisted up to 12 months. If you look at the effect instrument, a significant change that's considered to be clinically meaningful is a change of 19 points. We saw a median change of 32 points. So patients were substantially improved from a symptom standpoint. Similarly, if we look at healthcare utilization, so this is looking at cardioversions in the year prior to ablation compared to the year following ablation. emergency room visits in the year prior to ablation compared to the year following, and hospitalizations in the year prior to compared to the year following. If you look at the percentage of patients who experienced an event, there was a substantial reduction in all of those categories. Now, if you look a little bit more detailed in the table below, you see that the absolute number of events substantially decreased, as well as the number of events per patient. So however you want to define the metric of healthcare utilization, the year following ablation is substantially better than the year leading into ablation. So trying to get, again, a more comprehensive picture of the effect of an ablation on the patient, on the arrhythmia outcomes, as well as on the healthcare system itself. This paper was accepted into JACC Electrophysiology and should be available in the next few weeks. So that brings us towards the current analysis.
That is great, Jason. Thanks very much for sharing the results of CIRCA-DOSE with us. It's clearly an important study. It's a landmark study. I think in times to come, people would certainly put that on par with FIRE and ICE or even STAR-AF2, because it's changed a number of things for people. I think it's once again moved the emphasis of the definition of AF from sort of 30-second definition, which is always a bit bizarre as to why you would define anything more than 30-second of AF post-ablation as failure, to something that you can measure much better, such as AF burden, and correlate that with quality of life improvement, and obviously the other improvements such as decrease in resource utilizations. So congratulations for that study. It really is probably now going to be the blueprint of how studies should be designed and conducted in the future with loop recorders to give you an idea about AF burden. Now, that brings us to the important aspect that we were thinking of discussing today as to how do you define paroxysmal atrial fibrillation or persistent atrial fibrillation. I'm sure you'll agree that it's all very arbitrary, because we've seen patients who have very short duration paroxysmal AF. You take them to the catheter laboratory, sometimes they can have very advanced disease. They can have large left atria or diseased left atria. And then on the other hand, you can have patients with long-standing persistent AF who might actually have relatively healthy atria. So how do you define the AF and how in terms of its time course? And that's something which you looked at again, didn't you?
Yeah. So, I mean, you know this as well as I do. When we initiate the process of doing a research study, especially a multi-center study, especially a randomized study, there's a huge amount of planning that goes into it. And then you get to the grant phase, and then you finally launch and start to enroll patients. So the time lag can be substantial. And so where this came from was I remember sitting in a hotel with George Wise, who did Affirm back in probably 2013. And we were sitting talking about the planning of CIRCA-DOSE, and we sort of got into the history of where these definitions came from, right? And so your 30 seconds that you alluded to, I mean, really that was an extension from the VT literature. So a sustained episode of VT was defined as 30 seconds. And so if we're going to have a sustained episode of AF, let's just use the same. There's no basis for that. And then so you start to dig a little bit deeper and you say, well, why do we define atrial fibrillation like we do? And so as you can see on the slide, I've put the ESC guidelines recommending, why we classify them and then how we classify them. And so, within ESC, they use 7 days. Most guidelines around the world use 7 days, so the Canadian Cardiovascular Society as well as the American societies. But why it's 7 days comes back to a paper in the 80s where literally they just said arbitrarily, we decided 7 days was paroxysmal. Prior to that, it was 24 hours when they were looking at the early cardioversion studies with flecainide, oral, and IV. And so it is very much an arbitrary classification. And so if it's not based on pathophysiology, it's not based on outcomes, then arguably you could say, well, why are we using this classification? Clinically, we use it to characterize the severity of the disease, so that when I'm communicating with you and I say this person has persistent AF versus paroxysmal AF, it gives you a very different picture in your mind about who is this person. If we want to run a clinical trial, we want to have consistent definitions of the people in the trials for fear that we're going to be inconsistent when we compare across trials. But then that leaks out into the guidelines. So the guidelines say for paroxysmal AF, go down this road. For persistent AF, go down this road. In the Canadian AF guidelines, we have different levels of recommendation for ablation based on whether it's paroxysmal or persistent, right? We do make therapeutic choices on these definitions, despite the fact that they are arbitrary and despite the fact that they're not necessarily based on pathophysiology. So, our main goal, as we alluded to with CIRCA-DOSE, was that primary comparison of, what we do in terms of contact force and cryo. But our secondary goal was to question a lot of how we view AF and a lot of how we view the treatment of AF. And so one of the planned analyses, as you mentioned, was to go through these AF definitions. What we did within this study was trying to really get to the core of how potential misclassifications may affect those treatment decisions, and specifically as an ablation study, how that may affect post-ablation outcomes. So we took all the patients enrolled in the study because we figured we had a fairly homogeneous population of paroxysmal AF patients that had failed drugs. We used that 74 days of loop recorder monitoring going into ablation to define our baseline. So, we use the established definition of 7 days for paroxysmal AF. And so that blue line is that 10% of patients or so that were beyond 7 days. We used the 24-hour cutoff, which goes back to those flecainide cardioversion studies. And as an sort of analogy, seems to be linked to a higher rate of stroke and some of the other evidence we'll talk about later. We used the 48 hours. So if you notice in that ESC box, they specifically mention self-terminating in most cases within 48 hours, because that seems to be how we look at it. So we thought, okay, well, is 48 hours something that means something? And then there's somewhere in between. So there's people who are 2 to 7 days of AF. So based on that monitoring going into ablation, patients were stratified into 4 groups. And then all we did was look at the outcomes coming out. So we knew that contact force and cryo gave similar ablation outcomes. So we just lumped everyone together into one group and moved forward. And what you can see on this Kaplan-Meier curve is that same recurrence of any atrial arrhythmia, so any fib, flutter, atrial tachycardia. And you see the group less than 24 hours, and that black line has a significantly better freedom from recurrent arrhythmia compared to all the others. The interesting thing, though, is that if your episode was 30 hours, it didn't matter. You might as well have been more than 7 days. And so you see that the 3 longer durations, the durations greater than 24 hours, all cluster together. There does not seem to be any discriminative ability in terms of ablation success if your episodes were longer than 24 hours. I mean, the recurrence rate was more than double for each of those other groups. So by separating people out at a 24-hour threshold, we got a much better sense of what their arrhythmia outcomes would be. The interesting thing on the other side is that you can also look at that at burden. So in the gray on this slide, you're seeing the pre-ablation burden. So just what was their AF burden prior to doing ablation, and categorizing patients into those same 4 categories. And you see almost a dose response effect. Now, keeping in mind that this is a linear scale on the left side. And so you see that the AF burden, and this is showing you the median, the interquartile range, and the 90th percentile, just increases substantially as your AF burden, or as your longest episode duration goes up. On the flip side, when you look at the post-ablation burden, now we're showing you a log scale because, again, atrial fibrillation was substantially reduced post-ablation. But even on that log scale, you see the same sort of dose-response relationship where, based on how you were classified before you had your ablation, your overall amount of atrial fibrillation that you experienced post-ablation did increase incrementally as your baseline episode duration was longer. So again, giving you almost a pathophysiological link, suggesting that how people were categorized prior to ablation did mean something even after the ablation was performed. So, in context, we took that timeline, we took that information, and we started to think a little bit more about the previous studies. So here I'm showing you some cardioversion data based from the late 80s. And so they were using IV and oral flecainide. And what you can see here is that the success of ablation was much better if it was within 24 hours, but worsened substantially if it was more than 24 hours. And so you see that episodes with longer than 24 continuous hours had a significantly worse success.
Okay. Well, that's really hand. Oh yes, and you can actually show us now that the 24-hour cutoff is also what's now been shown to be predictive of increased stroke risk as well on all
Yeah,
the
and
device-rated tiles.
yeah, so what you're seeing here is an analysis from the ASSERT study. And so the ASSERT study is showing you that if you had 24 hours of continuous AF detected on a device, and so this is a pacemaker population, not patients who have necessarily any history of AF, you see that once the episode is longer than 24 hours, that 24-hour period seems to be a threshold of risk in terms of having a stroke. So those patients with AF episode durations less than 24 hours have much lower stroke risk, and even comparable to patients who have no subclinical AF. But those who have episodes over 24 hours, is almost an immediate rise in the risk of stroke. So again, lending credence to the idea that 24 hours seems to be a clinically meaningful threshold for continuous AF episode duration.
So do you think guidelines should move going forward? Should they change accordingly?
I think that it's important to consider the implications, right? So again, going back to where we started, where the definition of atrial fibrillation came from was not a place based on pathophysiology. It was not a place based on clinically meaningful outcomes. It was important to define it. It was important to categorize it. It was important to have us all speaking the same language. But now that we've sort of reached that point where we're able to have meaningful conversations, I think it's important to start to look at the implications of our classifications. And if the classifications are not entirely linked to the outcomes or linked to the pathophysiology, then it's time to maybe reevaluate it. As an aside, one of the other things that we did within this study was we had the physician classify the atrial fibrillation. And so this was done based on a standardized definition, and it was a standardized definition that was actually used in the first STAR-AF study. And so at enrollment, with no information other than the patient in front of you, they were classified by the physician. We then used that monitoring data over the 74 days and reclassified them using the exact same definition based on what was recorded on the monitor. And we saw very little agreement. So even you and I, as educated physicians who work very hard in this domain, struggle to classify patients appropriately. And so, the flip side of this is it easier to basically have a very simple definition of, did you have AF that lasted longer than 24 hours? I mean, that should be a fairly simple conversation, especially in the era of wearables where AF detection should be reasonable on an Apple Watch for 24 hours or not, right? So if we have a more pathophysiologically linked definition, we have a definition linked to outcomes, it's more easily accessible, and with the technologies we have available to us, we can categorize people more accurately, then I think that is a big shift in how we should look at this. Should we rewrite all the guidelines? That might be a bit too far. But should we consider this as we write the guidelines? Yeah, definitely. I think it's important to try and get to the problems that come from the AF.
Yeah. And the 24-hour cutoff is, in fact, quite easy for people to get their head around as well. Either you have paroxysmal atrial fibrillation will last a day, or you have sustained or persistent AF, or whatever that lasts more than a day. I remember many years ago, we had designed and performed a trial called SMANPAF, in which we randomized patients with, we called it advanced paroxysmal AF at that time. So any patient with a AF duration of greater than 24 hours, provided they had other comorbidities as well, such as diabetes, hypertension, etc., would be classified into one group, and atrial fibrillation lasting less than 24 hours in another group. And it was a randomized study in which we randomized patients to either PVI or PVI plus lines. As it turned out, the study was presented and published at the same time as STAR-AF2, so it was a bit lost in that process. But once again, 24 hours is the cutoff which we had used even for identifying patients with advanced paroxysmal back then. This is going back about 5 or 6 years now.
Yeah, and I think that, STAR-AF1, if you look at some of the definitions that they employed, I mean, they tried to break down their paroxysmals into high burden paroxysmal versus low, and that was what we had used in our other definition. I don't think the idea of trying to refine the definition of paroxysmal AF is a new one. As you've outlined, you've already done it yourself. But I think it's important to do that process and link it to some anchor that makes sense pathophysiologically and, makes life easier for clinicians.
Sure. Okay, sort of unrelated to this, but related to the study design for CIRCA-DOSE, do you think going forward, all AF ablation studies should have some kind of continuous monitoring as not only to identify the endpoints, but also to give you an idea about the baseline burden? Is that the way the field is heading, you think?
So I'm of two minds for this. So on one hand, again, if we link it back to, why are we doing this? At the end of the day, we're doing this to make patients better. So we're doing this to improve their quality of life. We're doing this to keep them out of hospitals, to keep them out of emergency rooms. So I think that the single definition of an arrhythmia outcome is something that needs to be reevaluated. I think it's important to have a more comprehensive, tiered or weighted outcome that includes those other factors, the patient-reported outcomes. And so, in CIRCA-DOSE, there's a 25% difference between any AF and symptomatic AF. Does that really matter to that patient in front of you? If you have an 80% chance of not feeling an AF episode in a year, I would argue that's the more meaningful outcome to the patient. But on the flip side, if I'm doing a technology comparison and I want to look at pulse field and compare it to the standard of care, then definitely I need to have continuous monitoring, because there's no way for me to know. You're going to get a whole lot of misclassification errors by the fact that you didn't have continuous monitoring. And then if you look at some studies, they'll have TTM compliance of 60%. So if you're not getting 100% compliance and you're not using continuous monitoring, then how are you able to make an effective evaluation of the differences between the groups? So I think that in some studies, definitely continuous AF burden is a huge factor, and loop recorders will become necessary to evaluate those outcomes.
There have been a couple of publications, again from Canada, from Atul Verma's group, showing a very good correlation between quality of life improvement post-ablation and the residual AF burden. Obviously, they didn't use loop recorders for their studies. They just used several sequential ambulatory ECG monitoring. In CIRCA-DOSE, did you find a similar correlation?
We did. So we actually have written that paper and submitted it about a month ago, where basically we were able to correlate quality of life score with improvement with AF burden. And we can show for a percentage change in AF burden, there's a significant change in quality of life score. And we can determine the threshold of change in AF burden that results in a clinically meaningful improvement in quality of life. So that is established. We're just waiting for it to be accepted, hopefully.
You do realize, of course, that you have now just invited yourself for another edition of this. When that paper gets published, we will have you back, if that's okay with you, and we can discuss that as well. Because as you said, from the patient's point of view, it's really about quality of life and how that improves with an intervention.
Yeah.
So that's perfect. Yeah. No. Do you have any final points before we wrap up?
No. I mean, I think that you and I have talked about this a lot, and I think there's lots of things that I'd be happy to discuss in the future if ever it comes up. So when we get to the point where that quality of life piece becomes a relevant conversation, then I'm more than happy to delve a little bit deeper into it. But I think that at the end of the day, clinicians and patients benefit from clarity, and they benefit from easy to use tools and assessment modalities and definitions. And at the end of the day, if we can improve outcomes, so if we're using a 24-hour threshold, maybe it means a lot for us to get onto the atrial fibrillation before it exceeds that number. And so if we can reduce recurrence by 50% by attacking it earlier, then that means a whole lot more to a patient than getting on it late and sort of having a worse outcome. So, hopefully, as we move towards early AF, which is our randomized study of first-line ablation versus drugs later in the year, hopefully that'll feed into these outcomes and we can look at it a bit more.
Fantastic. Well, thank you so much, Jason, for giving up your time and I'll let you get on with your day because it's quite early in the day for you in Vancouver. So I'll let you get on with it. And we hope to see you soon. Thank you very much.
Thank you so much. It was great to chat with you.